Doing well. How are you?
St. Patrick's Day. Oh, and I don't have
It
any
is.
green.
I
Ooh.
know. I don't. Well, I have a little bit of green on. You might not be able to see it, but it's like floral. So there's some green in there.
Yeah. Huh.
I've
Well,
got two. That's okay. You've got green on your background, so we'll count that.
that's
How's
good.
that?
Can I count? Okay. Otherwise, let me go splash them real quick. I'm surprised at myself.
We won't virtually pinch you. Don't worry.
Thank you. Thank you. As old as I'm getting, if I get pinched, that mark lasts forever. Fun part of aging.
My girls were in a frenzy this morning. They were like, "Oh, what green should we wear?" Because they wear uniforms, and so I was
Oh,
like, "Oh, I've got pins. Here you go."
yeah, there was one time not too long ago we were with the kids and the grandkids and we had to stop at a convenience store and run in and get something green because they weren't
Yeah,
going to school with that. They forgot, it's
I
like,
don't
oh,
doubt that.
thank goodness for Casey's.
Yes.
Green pins at the cash register. So we got them there. But
I know, I forgot all of that back in the day.
oh yeah, those are important.
Mm-hmm. Good morning, Ernest.
Good morning. How are you this morning?
Doing well. How are
Jane,
you?
good morning. I'm good, thank you.
I
I
do have
had
a
to go
question
rummage through
for.
my ties to find something that had green in it.
Did you? I love it.
It's years old, but it's got green. So anyway, I'm sorry you were going to ask a question.
Perfect. No, I was going to ask actually. I've heard you referred to as Ernie and Ernest, so I was just going to ask your preference.
Usually it's Ernie, but either way is fine.
Okay.
Yeah, I'm good either way.
Good to know. Well, I don't know how the weather is in Kansas, but it is a rainy mess this morning here.
It's cloudy and misty here in Council Grove. We had big plans, so it better be brief. Farmers need the rain, as we do in town too, I guess, so.
Definitely. All right. Well, we have Haley on and Christina. Should we give everyone I see people coming in. Let's give everyone about 30 more seconds to join and then we can start. And Haley, did you want to kick off welcoming the group?
Sure, I can.
Sounds great. All right. I see a lot of people coming in, so let's give them 30 seconds. And then Xavier, are we live?
Yes, ma'am.
Okay. Well, good morning, everyone. This is the Senior Care Taskforce Workforce Subgroup that's meeting this morning. This is meeting number 4 for the group. My name is Hina Shah. I'm a senior analyst at the Kansas Health Institute, and I will be your facilitator for this morning. So as people are joining the meeting, I will ask the chairperson, Haley Ordoyne, to welcome the group.
All right, thanks, Hina. Welcome, everybody. Excited to get started on this next topic because I think this one's a little extra powerful on expanding workforce and alternatives. So I'm eager to hear some information that we have come about that we think could be resourceful to the group and to expand upon any ideas the group has to tackle this topic. So thank you.
Well, thank you, Haley. So I've got the agenda up right now. And so your theme for today is expanding workforce and alternatives. So you do have some supplemental experts that you will hear from. Like last time, you'll put together a set of recommendations and we'll work through those recommendations as well. You will be hearing from 3 different experts. First, it'll be Pearl Barnett from Advancing States, and she'll give you some information about the worker matching registry and policies that MCOs can use to better advertise those services at the community level. You'll hear from representatives from each of the managed care organizations in Kansas, and they'll also talk about alternate supports to address the workforce shortage, such as individual strength and ability, supportive relationships, family caregiver technology, shared living, and community supports. Also provide some policy implications for investing in alternatives and how MCOs will mitigate workforce shortages. And then hopefully propose some ideas to better advertise the worker matching registry services. You did receive from KDADS a set of information and some context around self-direction, and the MCOs may expand on this as well. After that, you'll receive a legislative update from Linda Mowbray or Deborah Zare, and that will be on the bill to reauthorize use of trained temporary aides in long-term care. And so those are your 3 experts for this morning. So before we get started, though, let's kick off this morning with a quick introduction of everyone and then briefly provide 1 or 2 sentences that you would like members of this working group to keep top of mind as you hear more about the theme, expanding workforce and alternatives. And I'll call on you. So I'll start with you, Haley.
Ah, the beauty of being the chair. All right, I'm Haley Ordoin. I am here as co-chair, excited for this topic especially. I'm representing Kansas Adult Care Executives, which is administrators and operators of long-term care senior living throughout the state of Kansas. And I'm just eager, as always. I'm a nerd. I look forward to these meetings because I think this is a place where a lot gets done because you have a lot of the people in the trenches that really understand what's going on and the daily struggles. So I think these are the most brilliant minds to have a grassroots effort for things. So that's all I have to say.
Thank you. Lee?
Good morning, everybody. I'm Lee Chaffee. I work at Brewster in Topeka, Kansas, and I represent adult care homes on this task force. Happy St. Patrick's Day to everybody. I just want everybody, I really am encouraged that we are talking about self-direction. I do know every individual that needs care has very strong opinions about who cares for them. And so there are a lot of creative solutions to caring for people. And I really appreciate that we are looking at what those creative solutions would be in any setting. So that's what I would like to say. Just be creative.
Thank you. Ernest?
Good morning, Ernie Cutzley, ARP Kansas. Thank you for this meeting and happy St. Patrick's Day to everyone. I would just think that as we look at expansion alternatives and those kinds of things for workforce, that we have safety for those people who use those services is the number 1 issue on our mind. So thank you.
Thank you. Deborah? Oh, I thought I saw her, but I guess not. Jamie?
I'm here. Yeah.
Oh, you.
Yeah, I just was having trouble. My screen looks a little different this morning.
Okay.
It's always good to be with this group. Deborah's there from Leading Age Kansas. We represent nonprofit aging service providers throughout the state. I'm really glad that we are looking at this topic today. I think that we have opportunity to think more creatively about how we get the work done than what has historically been the parameters, and we need to really look at that in light of the workforce crisis. So happy to be here. Thanks.
Thank you. Linda?
Linda Mowbray, Kansas Healthcare Association, Kansas Center for Assisted Living. We represent the continuum of care across the state, both for-profit and not-for-profit providers. And for me, I really like the idea of, what are our other options? Who are other people to pull from? And I would echo Ernie Cutzley's sentiments that in doing this, we have to make sure that we have safety of the individual that's receiving the care and quality of the individual that is providing the care. Thank you.
Thank you. Jamie?
I'm Jamie Gideon with the Alzheimer's Association. I'm looking forward to developing long-term solutions today to the workforce, and also to make sure those that are providing the care are adequately trained and prepared to care for our loved one.
Thank you. Jan? You're on mute, Jan.
Thank you. Silver-haired legislator, caregiver, and CNA retired, pastor retired, all of those things. Mother-in-law currently in nursing home. The important thing to me today is that the word get out that there are alternatives, and especially in the rural areas, we're underutilizing the services that could be available through Area Agency on Aging. And that's for several reasons, but as we've gone through the process, we've been amazed at the information clearinghouse that they provide, and we didn't know it at the time, but we know it now, and it was helpful. And those kind of things, as there's so many of us at the same time, I'm glad we're going to bring that out and what else is out there as we make choices. Thank you.
Thank you. Kelly?
Kelly Summers. I am director of the Kansas State Nurses Association. We represent registered nurses, but we also represent quality health care for everyone throughout Kansas. So we always look at those issues. We've been doing a lot of studies actually since 2016. We knew that we would be in a staffing crisis by 2030. Obviously, COVID exacerbated that situation. And so I just look forward to the opportunities to share what we've been working on, some of the issues that existed prior to COVID, also that we can look at how we're going to work on those in the future, strengthen those ideas that come from RNs, LPNs, CNAs, and to share that information so we can actually grow our workforce with workforce that actually has that quality education and skills moving forward to prepare for our seniors so that in turn they have quality health care. And I think there's ways to look at it and solutions to have, which actually makes it better than what exists right now.
Thank you. Christina? I think you're on mute. Or actually, there you go.
Can you hear me now?
Yes.
Okay. Christina Rudisil, Johnson County Community College. I'm looking forward to looking at how we can help on the education side to make sure that everywhere from CNA, CMA to, RN and MSN can help and everything in between. In addition, how we can partner with our communities to make sure that we are feeding them staff as quickly as quality as we possibly can. So
Thank you. And Camille, would you mind introducing yourself and provide maybe a brief 1 to 2 sentences on what you want the working group to keep top of mind as you hear more about the theme, expanding workforce and alternatives?
Camille Russell, State Long-Term Care Ombudsman, and my goal would be that we do look at we always look at how can we rather than what we can't do, and that we always look at ways to have grow our workforce, that they are supported, respected, and well-trained, because they'll pass that on in the care that they deliver. And that we do also look, like Jan said, to alternatives to how we are doing things now that allow people to, quite frankly, stay in their homes longer.
Thank you. And I want to make sure I didn't miss anyone. I think Dan is out on spring break. Sean, are you on? All right. Well, then let's go ahead and dive in with our first supplemental expert. Pearl, would you like to introduce yourself and provide a few comments? I think you're on mute. There you go.
Hi, thank you for inviting me today. So I have a quick presentation to share. I am traveling this weekend. I'm in a hotel room, so let me get my setup together and then I'll go ahead and share my presentation. Oh,
And I've given you privileges, so you should be able to. There you go.
awesome. Can everyone see it now? Okay, excellent. So I'm Pearl Barnett. I am with Advancing States. Advancing States is the association that represents all of the state, aging, disabilities, and long-term services and supports directors across the country. So many of you, I heard many of your organizations, we partner with most, if not all of your organizations, either at the national level or as an extension of our state partners such as ks, which we work with quite a bit. And so I'll just go a little bit about Advancing States and then quickly go into the Connected Care Jobs solution that we have developed and are enhancing to address multi-purpose workforce management tool that would be administered by the state. So again, Advancing States, our mission is to sustain state systems, delivering LTSS for older adults, people with disabilities, and their caregivers. We have several areas that we spend most of our time. That is community integration, health and wellness, consumer access, organizational effectiveness, elder justice, and quality outcomes. So we work with all of our state partners to really advance these areas. And we do this by helping the states with leading, innovating, collaborating, advocating, informing, convening, and consulting. So many of you may know us from, we are the administrators of the National Home and Community-Based Services Conference that meets annually in either Baltimore or DC. And so that's one of the things that we do, but we work with the states year round in different areas. So I'm here to talk about Connected Care Jobs, which is a workforce solution that we developed that was a response to really COVID. So in 2019, our board of directors, who are state directors and leaders, met and said, hey, we need to make sure we're focusing on the workforce crisis in our strategic plan for 2020. And then March 2020 hits, and that, as was stated, was exacerbated by the pandemic. And one of our state partners reached out and said, we need a tool to help connect nursing facilities at that time with individuals seeking employment, because we have a lot of people who are not working. We have nursing facilities that need staffing, and we need something to help match these people together to create an opportunity for discussion and conversation. So that's what we did. We looked at some of the states that were developing things, and we found that the state of Massachusetts had developed a tool that was, bringing in the information from their nursing facilities and also bringing in information about job seekers in the area. And they were manually connecting those job seekers to the nursing facilities. Well, we took it a step further and worked with one of our partners who really helped us develop out this software to create an algorithm where the job seekers would put in their information. The providers, which we expanded it beyond nursing facilities to adult day providers, to HCBS providers, really whatever providers that the states really identified in their state needed additional workers, which we know based on the workforce issue, it's quite a list of different types of providers there. It creates an algorithm to connect them based on availability, location, and willingness to work in their area. So that's what we did in May of 2020. We launched that website, and now we have 7 states that are currently participating in that website. But with ARPA, as the ARPA Enhanced FMAP, a part of our work, we looked through those ARPA plans and we found that the states really wanted a more comprehensive way to collect information and support workforce initiatives within the state. So we started having conversations with different partners, and Alterum is a partner that we found that does online job registries. They will be able to enhance the matching services. They do a learning management system, and we could put it all in one platform that would really help not only follow the job seeker to connect them with job openings, but also creating an employee profile that is, or a candidate profile that is really connecting all of their training, development, credentialing, certification, all of those things in one space for the providers, employers to really know who is in the LTSS network within that state and who is available for different openings, opportunities, as well as provide information to the state directly of how trained their workforce would be, what kind of credentials there are, because right now we know that most states, if not all, don't really have an exact number of the workers in the DSW system in their state. There are estimates based on providers' information, but knowing the exact number is something that's very difficult for states because the states are not collecting that direct information. So we are working to enhance our Connected Care Jobs platform to include all of these areas. So enhancing the job posting, like I said, creating the candidate profile. It would be a state repository for credentialing. The trainings would be available in the learning management system. Advanced searches, again, the auto matches, advanced reporting, a collaborate area that allows the states as well as providers, employers to provide resources to their workers of interest, the job seekers, the workers, the candidates, and then also an enhanced resource library that is available. So these features, we do go over kind of what they include. I think they're pretty self-explanatory, but that state repository would be able to really track the training and certification of different workers. And as we've talked to states, they want to create different pathways for workers to enhance their abilities as well as kind of steps to move up in the workforce in the area. So working with states to create those opportunities. Again, talked about the candidate profile that would follow a candidate no matter whether they're working or seeking employment, similar to what you would see, with your LinkedIn profile, but this would be specific to your LTSS work. Job postings, the auto match feature would still be available. And then on this slide, we talk about the trainings, which would be that in learning management system, the Collaborate, which would be that forum. But this state workspace is also a very important place where the states are able to pull the statistics, see the initiatives, push out policies and roadmaps. So it's really creating this open communication mechanism with the workforce, the employers, and the state who really oversees long-term services and supports. And then, of course, having that opportunity for enhanced reporting. So this is a shared services model. So all of the states have the ability to participate. We represent all of the states. All of the states have the ability to participate in this. And with that, you're really sharing the cost of the platform across the country. So building out something like this in one state is millions of dollars. We know that. Building out this with across multiple states, you're splitting that cost. So it's really creating an opportunity for the states to really support one another, and it's creating a national platform as more states come on. So right now, where we are, we're at the state, we're at the point of recruiting states to participate. I don't have any information that Kansas has signed on yet, but hopefully after this meeting, we might have some more discussion about that. We will have a group of states to participate. The development of the platform, the enhancements of the platform will last over the next 9 months. And then the states will be able to use this enhanced platform beginning in 2023. During this time, we have the ability to work with states to use the enhanced FMAP dollars, as well as work with states to make sure that the needs of the states, there are also state-specific needs that are addressed within the platform. So again, this is the timeline. We're beginning defining the scope in April. So we're starting pretty quickly. And then over the next 9 months, it'll be the build of the enhancements, and then we'll be doing some user acceptance testing. And that is pretty much it for what we're doing here at Advancing States. Am I still sharing?
You are still sharing, Pearl. Thank you so much for being with us this morning. Before we go to questions, though, I did want to clarify that Sherry Jared, I hope I said your name correctly, is here from KDADS, basically subbing in for Dan Goodman. So Sherry, do you want to introduce yourself really quickly, just so everyone knows there is an agency representative on?
Sure. I don't know if you can see me or not, but my name is Sherry Gerard, and I'm subbing in for Dan today. I'm the Director of Nursing Facility and Adult Care Home Programs at KDADS, and I'm new to this job as of the first of the year.
Welcome. And we don't see you, but we'll give you some grace to work on your camera.
Well, I'm looking absolutely gorgeous today, so if that helps.
Terrific. And then as we start the Q&A part, remember your meeting commitments to come ready to discuss and compromise, keep remarks succinct and on topic. Don't hesitate to ask clarifying questions, and remember to introduce yourself before asking the question. So we'll start with Camille.
Good morning, Camille Russell, Kansas State Long-Term Care Ombudsman. And Pearl, my question to you would be, in the states that you know that may be utilizing this, and I want to make a comment that I think noticeably absent from our committee maybe is a representative from Department of Commerce with the Kansas Works or Workforce Investment Act programs. Is that where you're connecting these in other states? This type of is there a way to connect to them so that, you know, it is all kind of more of a cohesive, it's not another fragmented piece of, you know, job recruitment?
No, so that's a great question. So what we have found, normally the lead with us would be either the aging agency in the state or the Medicaid agency in the state. However, we have found that it is absolutely imperative for the states to work across agencies to make this effective. So the states need to work with Medicaid, aging, commerce, all on the same page for this to be an effective tool. Even credentialing, licensing, because sometimes that's in a different agency. So we really, in our discussions with the states and the onboarding, we talk about the collaboration that is required at the state level to make a state workforce platform really effective.
Thank you. Deborah?
Yeah, thank you. And Pearl, so glad you're here. First time I've heard about this. I'm wondering who the other states are that are already in, and though especially those who have been in for the longest time, because I'd like to talk to my counterparts in those states about the on the ground application, how it's working, that sort of thing. So, who are the other states?
So I just want to point out that right now we're just doing the auto matching. So these enhancements are not a part of what's happening right now.
Okay.
Currently, the states that are using this is Colorado, Alaska, Connecticut, Michigan, Washington, Oregon, and I'm missing one. Maine. There we go. And I do this from memory, y'all. The states that have signed up for the enhancements are we have 5 now who have signed up for the enhancements because we went from a free system to now a paid for state shared cost system. So that's a little bit different. But those will start, we will start working on that process beginning in April of developing out the next steps in the build for the enhancements.
And who are the 5 states? You said 5 states have kind of signed on saying they want to do these enhancements.
Yeah, let me see if I can
Putting
do
you
this
on the
from memory.
spot here.
Yeah, I know. It is Colorado. So Colorado is our initial state. They started from the beginning with us and they're going on to the next phase with us. We have Wisconsin, South Dakota, Texas, and I believe Rhode Island, but Rhode Island is confirming this week.
Okay. All right. Thank you.
And we have several states that are still interested in seeking the best way to procure, work with the contracting of it all.
Thank you.
You're welcome.
Thank you. Ernie, did you still have a question? I noticed you lowered your hand.
Yeah, Deborah, thank you for asking. I appreciate that. I think it was answered.
Perfect. Haley?
Thank you. And yes, Pearl, thank you for being here because this likewise, like I've heard the concept mentioned, but I haven't heard in depth really about it. So I appreciate that. And I don't know. I'm like, wow, this is a no-brainer. Why wouldn't we utilize something like this? Do you know if we were to, speak to the committee or, even have you possibly speak to the committee as a whole, what is the cost estimate? I know you said it's, divided.
No, the cost is $250,000 for the build year and then $150,000 for maintenance years. So we know that based on the cost of the work, every state there is work to bring them on because every state has different requirements. So we have done the cost based on how we onboard states, as well as how we support all of the states in their separate requirements in an ongoing way. So it is a flat rate for all states to join. But again, if you're doing this from a state by state perspective, you're paying millions of dollars and you're doing much more of the work on the state side, where we're taking that on our side at Advancing States.
Okay, thank you. And then this is something that would be resourceful among all sorts of long-term service supports, everything from HCBS services, long-term care, skilled, individualized persons.
Absolutely. self-directing as well. And it's very important for us to hear from the states and the stakeholders about how to make this as easy to navigate for people who are self-directing and not overwhelming with information. So we're working with the states as we're moving forward, pulling in that self-directing population to make sure we're not overwhelming with too much.
Thank you so much.
Thank you. And Pearl, before I go to the next questions, do you still have time? Because I know you are battling time zones right now.
I do. It's 7:30 here, so I'm good for a little bit.
Terrific. All right, let's go to Kelly first and then Linda.
Hi, Pearl. This is Kelly Summers from KSNA. We're also constituent members of ANA, and these are conversations that we have all the time, and I'm glad that you brought up numbers and how difficult it is to track, because we can look at state numbers, national numbers, and this or that. They never match. So within this, is there ability to know who is actually employed versus those who aren't right now? Because I can say right now, like, at the state level, we have 10,000 LPNs, but I know 10,000 LPNs are not working right now, but they're maintaining that license. So do you understand my question? That's a tough one for me.
No, that's exactly what we're doing here. Is like the candidate profile follows the person. So when you attach to an employer, then we're identifying you as an employed candidate. When you're not attached to an employer, then we would be identify you as a non-working kind of potential job seeker in the market. Or I mean, you may even identify as not working, not looking for work in the system. So really creating that opportunity to, and one candidate can attach to multiple employers, because we know that happens. And sometimes right now we might be documenting them multiple times because we're documenting them with this employer and that employer. And we know that a lot of direct services workers need multiple jobs to pay their bills. So we need to make sure that we're creating a system that is going to track them at where they are, no matter how many places they are.
I think it's very interesting, Pearl. So I appreciate the presentation on that. And because I'm with ANA also, I can reach out to my fellow directors of the other states too, because I'd love to get feedback, including, they're all amazing states with amazing directors. So thank you so much for the introduction to all of this.
You're welcome.
Thank you. Just to make sure we have time for the other presenters, Linda and then Christina. And if there's any other questions, I'll send them to Pearl by email, okay? Go ahead, Linda.
Linda Mowbray, Kansas Healthcare Association, Kansas Center for Assisted Living. Thank you, Pearl, for your presentation. It was very great information. One of the things about me is that I always want more. When you are working with these other agencies across the state, do you see the capacity to tie in background checks, registries, so that the individuals can be vetted by the consumer or by the nursing home? And if you are anticipating doing that, if someone has a flag, will they remain on your registry, or will they be quarantined, so to speak? We don't want to discount them and not, know that they're out there, but we don't, if they're not eligible, we don't want them out caring for our folks.
Yeah, so one thing that we've talked about is connecting with like LexisNexis to do the national background check screening for the individuals in the site. And because states have different requirements on what is accepted or not accepted, we would need the state to make a decision about whether that person would be available, or the employer to make a decision on whether that person would be available to hire, because that is different per state, and within states sometimes it's different per position that people are seeking. So we would not take them out based on a background check, but we would leave that decision up to the state or the employer.
Thank you. Go ahead, Christina.
Hi, Pearl. Thank you for presenting to us today. Christina Brudeso at Johnson County Community College. My question is in regards to how the data will be inputted. Are we relying, or is the system relying on employers, or is the system relying on the caregivers themselves to maintain that database in regards to how it's inputted?
So that's multiple ways. So the state has a part in the data input. So many states have already databases of certified people that they have in their, let's say, Department of Health licensing system, that we would work with the states so that information is uploaded into the system. And then those people would get a notification to say, hey, you've been uploaded to the system. We need you to log in, create your profile, and provide steps that way. The employers would also similarly go through that same steps, as well as the employers would be able to begin making the connections to their employees. And it would be a joint responsibility, the state, the employers, job seekers, candidates, employees, to make sure that everybody is kind of keeping track of themselves. So it's different parts is going to be responsible at different areas.
Thank you.
And also, I mentioned like the state holds a lot of the credentialing information. So the state would then need to be able to update credentialing information. So it'll be different areas would have different people responsible for input. Thank you. Well, I don't know.
Apologies. I was frozen there for a second.
Okay.
So thank you very much for being with us this morning. If there's any further questions, I'll make sure to send it to you. You are welcome to stay on or hop off. I will leave that to you. But now we'll turn to our MCU representatives. And so we will start with Melody from United Healthcare, and then Jennifer from Aetna, and then I think I see Nan on, so Nan from Sunflower Health. So let's start with you, Melody. Melody, did you have a presentation, or were you going to speak?
Let me get all my things going here. I do have a presentation. I'm actually just going to pull from the presentation from earlier or last week, since we didn't really have a lot of time to get through a lot of that.
Terrific.
You'll give me just a minute to get things situated. Okay, I'm going to try to share. Cool. You can see my presentation now?
Yes.
Great. Okay. Melody from United. I'm the Health Services Director here at the Kansas Medicaid plan. So I'm going to skip over the workforce shortage. We all know we have a workforce shortage issue. So some of the things we talked about, I briefly was able to touch on last time and like to spend a little more time on this time, is alternatives to workforce. So we do have some alternative payment arrangements where we can do single case agreements to pay enhanced rates or pay mileage reimbursement for individuals that are difficult to staff. But we're also looking at other options such as technology solutions. And I briefly touched on our CareBridge partnership last week, which is a technology solution that we're using with members on the physical disability, frail elderly, and TA technology assistant waivers, where they receive a tablet and they have access to a care team 24/7 within their home. The tablet is free to the member. It's delivered to them. It's set up. They can have assistance getting it set up if needed, and they're able to connect to members of the care team by pushing a red button. And we are seeing quite a bit of utilization of the red button with our members. Most often, they're contacting the care team for medication refills. Or for they're experiencing some kind of an acute symptom at that point and needing some assistance. And we've been able to avoid ER visits, inpatient visits. We're seeing a lot of positive feedback from members for that. And again, it's really kind of they're having that direct connection to a caregiver available to them 24/7. So sometimes we have maybe the PCP office is closed, or we had a success story this week that they shared where the PCP was on vacation and the person was not able to get what they needed from the PCP's office. So CareBridge got them what they needed. They avoided an ER visit, connected them back with the PCP when the PCP was back in the office, and member was super grateful to have that additional support. And then we're also piloting another technology solution. It's an Echo, like an Amazon Echo device that's being provided to some of the members on an HCBS waiver. It's a pilot again. We're focusing on about 100 members to start this pilot. And the member receives this device, it's voice activated, and it will allow them to connect with their care coordinator, with their provider, and with members of their care team that they submit to us that they want to have included and would have access. So that could be members of the family. So part of the goal around this is to just have more face-to-face communication with the members. We've not been able to be out in the field, so this will allow us to have more of that virtual face-to-face contact. It's also an ability to increase telehealth visits for some of our members who just don't have access to the technology to be able to participate in telehealth. So we're partnering with one of our BI waiver providers who has already been doing telehealth with some of the members on the waiver, but is going to be able to expand that to additional members who didn't have the technology to be able to participate with that service. So we're pretty excited about that. We're piloting it with about 100 members and about 12 care coordinators. So we want to make sure that it's working smoothly. So the care coordinators are receiving the technology and the devices this week and next week, and then they will start to use them and make sure that it's easy to use. They come already set up, but we also have the ability to use the Geek Squad to be able to actually go out to the member's home and help set it up. So we've got some care coordinators that are receiving devices that are set up. And then we're having some that are receiving devices and going to have the Geek Squad actually come to their home and help them set it up so they can have that member experience and make sure that it's working smoothly. So we're excited to get that one started. An additional one that we're looking at to really address loneliness and social isolation is it's an app, and this one we're just in the exploration phase, but it's an app technology where the member is able to interact with some animated technology through the app, but they're also able to, if they want to and score appropriately, they can connect to a real person who is available to them 24/7 and who's trained on loneliness, depression, isolation, and how to address those issues with the member. So that will be another possible pilot opportunity for us that I think could help address some of our members' issues around isolation. And then we have a variety of value-added benefits that are available to members who receive home and community-based services, and then members who don't. I tried to pull out the ones that really are geared more towards our home and community-based service members. So we have our Healthy Rewards program where they can earn debit cards to completing health screenings that they can use to purchase CMS-approved health items. They can receive one full set of dentures every 5 years if they're on the frail elderly, and it should say PD waiver as well. The free smartphone, I really feel like the technology piece, I mean, there's a limited amount of workers. We know that workers, the rates are an issue, availability is an issue, but we also know that folks are just wanting more of that remote type of job for their own safety and be able to work from home. So I think technology solutions is really where we need to be focusing and looking for opportunities. So we are excited about those additional opportunities. We do provide internet access for persons on the FE, PD, and IDD waivers. We have a lot of initiatives around social determinants of health ongoing at the health plan. So we have some housing assistance funds. We have food access programs where members can receive home delivered meals. We have an employment specialist who works with folks who are interested in getting back to work and what that might look like. That could be completing a GED, it could be a coding class, all sorts of assistance with applications and interviewing process. And then I was just able to briefly touch on our dual special needs plan last week. But for those members who are dually eligible, so they qualify for both Medicare and Medicaid and live in the counties where we have the DSNP, they also have a variety of additional benefits that are available to them. And some of those things include an over-the-counter card that they're able to use $175 a month to buy fruits, vegetables, dairy products, meats, and over-the-counter items. Dental, up to $4,000 for preventative and comprehensive dental services. Additional vision, foot care, hearing. There's an additional meal benefit that can be an add-on to the other meal benefit, zero copay for up to 42 meals for 21 days. And that's following a hospital stay. And then telehealth too. Again, that's that technology piece that I think is really important. House calls, yearly checkups at home to help stay up to date on your health. My grandmother actually receives house call visits, and she loves it. She loves the fact that somebody comes to her home, does her all of the assessment and the house call visit. She really likes it, and then she gets kind of that reward card that she can purchase things from Walmart or wherever she wants to purchase them from. So she really likes that program. Fitness, getting members out and staying active. There's a fitness program called Renew Active, or they can also receive a Fitbit if that's something that they're interested in. And then the personal emergency response system, which sometimes that can also help reduce caregiver hours needs. If they have the personal emergency response system, you may not need someone there with you all through the night if you have that benefit in place. Chiropractic care, lots of transportation benefits. So as a value-added benefit, they get 12 additional trips outside of the non-emergency medical transportation. And if they're a DSNP member, there's an additional 48 flexible trips that they can use for community outings, going to the pharmacy, picking up groceries. It's a great rich transportation benefit. And then they also have, of course, access to the nursing hotline. So I think I went over last time and didn't allow Aetna and Sunflower to have much time to speak. So I'm going to stop there and let it go back.
Thank you, Melody. Any clarifying questions right now? Otherwise, I'll have the other two MCOs present as well before I open it up to more questions. All right, it looks like there aren't any clarifying questions. Jennifer, would you like us to share the screen or would you like to share your screen?
If you have it handy, if you can pop it up, that'd be great.
Sure.
That way you don't end up seeing my email screen or something.
There you go.
Okay, thank you so much. So I'm Jennifer Parente. I'm the Long-Term Services and Supports Director for Aetna. Thanks for having me today. I have a very short presentation, mostly focused on just around how kind of we're supporting providers and members with the workforce shortages. So one way we're doing that in my department is just throughout the last couple of years, especially, is really looking at just our regular day-to-day work with members. So our contacts with members. What we've tried to do is just stay better connected. So a lot of times, you'd support a member and you do see them initially, maybe see them in 6 months and do an annual assessment. And what we've really done is tried to do kind of an enhanced version of our touch points and really offer an extra kind of level of support where we've increased our telephonic support with members. We're trying to stay in better connectivity with members who are maybe at risk, who have a lot of changes in their services and supports. Maybe there's some gaps in utilization. They're really at risk. Maybe they don't have a lot of family or informal supports. And for those members, we've just tried to, again, enhance and increase those touch points where we're staying connected with members. And we're really trying to kind of dig in and make sure that as we're talking with them, not only do they have a really good service plan, but that those services are actually being delivered and those members' needs are being met. So we've, again, increased some of our intensity of some of our touch points with members, especially during the pandemic when there's just been a lot of fluctuation and change in services and workforce and actually the delivery around those services that we've authorized. Additionally, it's kind of making sure that there's not just a really nice backup plan that looks really good on paper, but really digging in with members and their families and their supports and their care team to make sure that if they are in a situation where somebody doesn't show up, what is the backup plan? Do you access family? Do you have other workers that can come in? And really, again, just having those kind of enhanced conversations around the day-to-day and making sure that services are being delivered and that members' needs are getting met as their needs are changing and as their providers are changing. Of course, we do a comprehensive assessment for members and a specific assessment to determine how many services, frequency, and duration of services members can receive. And we really try to do that on a person-centered support approach where we're looking again at what are the current supports for that member. And again, as things are changing, that we're reassessing and changing that service plan to kind of meet their needs as in real time as things are changing for that member. One thing that's kind of always been a given in LTSS, and we're so lucky in Kansas to have self-direction and have members have the ability to hire those people that they really want to work for them. We cover that and we cover choice with members every time we're talking with them about their service plan, every time we're redoing a service plan and completing an assessment. But what I've asked my team to do is really kind of dig in. What is self-direction? Are we explaining that? Are we explaining the responsibilities around that and what that means for a member and what kind of opportunity that can be for a member to be able to have that control over their care? And then offering them just resources in terms of, hey, I'd like to do that, but maybe it's kind of scary to think about taking that on. How can we help really kind of paint that picture around self-direction and what that could, and the opportunity that could be for a member to be able to select and hire their own staff. And again, making sure that we're providing those supplemental resources so that they have the ability to do that if they're making that choice. And sometimes just getting creative about, maybe it's a little bit of self-direction, maybe it's a little bit of agency and direct, maybe it's some remote patient monitoring services, just trying to get creative and make sure that we're attaching as many supports as we need to and as creatively as we can around members, especially as we see, again, the fluctuation in the workforce, that we're trying to build different levels of supports around those members. The flexibilities under Appendix K during the pandemic, they did open that up for family members and guardians to be paid caregivers. That has been a lifesaver for some of our members who didn't have that ability to hire that particular family member before, but now they can. So I know that there's some discussions around maybe maintaining some of those flexibilities even after the pandemic, just because it opens that pool of folks up that those members can actually select to work for them. So that's been really a great safety net for our members during the pandemic. And then just offering, again, remote patient monitoring services. We really tried to open up those kind of technology types of services so people have, if they can access different supports through, and just home delivered meals. Again, any kind of opening up, just looking beyond what's in the select menu for that particular member under the services they're eligible for, but is there things that we can do to be creative and kind of think outside of the box and supplement a service, and that's really going to be able to provide that safety net for the member. So just improving access. I mean, one of the things that we try to do here at Aetna is just be in lockstep with our provider relations team. We have, we're referring and communicating with providers on a consistent basis on the clinical side, but we are hearing from providers how difficult things are right now in terms of the challenges for recruiting staff and retaining staff. So as my folks on the clinical side are saying, hey, we're having some challenges in this particular area of the state, or with the, particular group of members under a particular waiver, we're trying to communicate that back to our provider relation team kind of on a week basis, so that we're not only kind of referring from our side on the clinical side, but that there's a follow-up conversation happening from a provider side about how we can support providers. What are the challenges that they're having? And so we have a better understanding of, okay, what are the trends that they're seeing, and what do they need to better be able to provide support to members? So again, we're having sort of weekly task force meetings where we're constantly communicating with our provider relation teams and making those outreaches to providers so that we do understand what the challenges are and we can try to problem solve and solution with them. We are outreaching providers and with Lord Christensen's exploring out-of-network providers. Obviously, one of the challenges we're hearing most is that, providers need to be able to offer a competitive wage. So on a case-by-case basis, again, we're having those conversations with providers. We're looking at what our membership needs are, and we are doing some enhanced kind of arrangements with them about enhanced rates on short-term basis, just to try to get those services in and authorized for those members. So again, those are part of those conversations that we're having about what that provider needs and how we can get services going for that particular member. Monitoring claim, ensuring payments are timely. Again, some of the things that we're responsible for doing, we're just making sure that we're trying to reduce the administrative burden as much as possible for providers. We want them focused on hiring staff and being able to provide the services needed to our members. So trying to make the administrative pieces as easy as possible. And then assisting members with contacting providers and offering choice. Again, I think it's just making sure that we're having a constant conversation with the member about what their options are, who the providers are that they can work with. If they're struggling with a particular provider or somebody's not consistently coming out to their home, how can we help support that member in that conversation with the provider? And then how can we help support that provider with actually delivering on the services that that member needs? And then I think I've mentioned this in a previous meeting, but one thing that we're doing in addition to just talking to members and talking with providers and kind of adjusting as needed in terms of care planning, we're also just really trying to take a very close look at utilization of services, because sometimes we won't hear from a member, or we're hear from a member that things are going fine, and we might double back and look and say, oh, wait a second, we see a gap or a change in the utilization of services. So we use a lot of data-driven reports where we're constantly pulling, like on a month-to-month basis, where we're looking at what the utilization is for each member in that particular service category. And then again, if we see a gap or a reduction where we know a member needs a certain amount of care to be healthy and safe, if we see an adjustment there on the utilization of that service, we're following up with that member saying, okay, we noticed that there was, less services utilized. Is your worker coming out? Are you communicating with your provider? Is there something that we need to adjust on your care plan? So again, just kind of connecting all of those dots, making sure that, again, what we know that member needs is actually getting provided on the provider side. And that's all, I believe that's all I had.
Thank you. And before we move on to Nan, I do want to make one point of clarification. The 3 MCOs did present to a different working group. It was Working Group B, Access to Services. So while some of those members do overlap, since this is a subgroup that pulls from 2 different working groups, I just wanted to make sure that our presenters were aware of that. All right, Nan, you are next, and I will stop sharing the screen.
Can you hear me? Great. Sorry, I'm using a different headset. So I do not have a PowerPoint, but I do have just a Word document that I very recently, in like the last few minutes, sent to Hina. So I'll try and go through a few of those details that we've talked about on the other work group, as well as just highlight a few answers similar to what Melody and Jennifer shared. So I am the Senior Director of the Social Determinants of Health and Pathways team for Sunflower Health Plan. I work across many of the waivers as well as support members who are in nursing facilities and or those that are repatriating. So my team has kind of a broad array of things that they do. Let me see. I'm sorry. I know you said I could share, so let me try. We'll see if it works. I'll share it so you guys don't just have to look at me. Oh, maybe. Hold on. There we go. Okay. So one of the things that we have done in regards to the, in response to the pandemic is hosting biweekly LTSS stakeholder meetings. And really that was kind of what have we seen that's changed? How is that working? That is a collaboration with people from the state, as well as individuals from nursing facilities, some of our home and community-based services providers, the area agencies on aging, many different groups participate in that. And really through that, that's one of the ways that we're really trying to monitor what can we make sure we're doing to continue to be responsive to the needs during that. The interesting part, based on the questions that you guys have, is that last week, we were talking specifically about this personal care services and how we can maybe either leverage the current database, which Kansas does have one that they're using, which is rewarding work, and are there other considerations? I really appreciate that Paula shared all those details about Connect to Care. Some of you may remember from the main task force that Stephanie had shared that Centene purchased that, our parent company, Centene, purchased that platform and gave that to advancing states to continue building out with other states. So, but we will have a meeting next week with our FMS providers to talk about, are there ways that we could better support individuals? Because we know when we talk about this direct care workforce, as Paula highlighted in her presentation, many of these individuals have 2 or 3 jobs. So if they are already approved to work with one person and want to provide services in their area to another person, how can we make sure that that can happen in a more seamless way? So before the pandemic, and even more since, Sunflower has really, with that group and with our other initiatives, focused on social isolation, chronic disease management, as well as the direct care workforce. Today, I'm going to talk mostly about the direct care workforce and highlight some of the areas that we're doing. Some of the things that we did last year were an emergency backup plan. We collaborated with the National Centers for Independent Living and completed that for direct care workers. And we also worked with the National Advocate to review and provide best practice recommendations. Another thing we did was expanded the use of technology. So right now we're working with 2 in-state providers to really look at how can we use that smart home technology and 24/7 remote monitoring to better leverage the supports that individuals need. Family caregivers, the Appendix K initiative, or the Appendix K flexibilities have given us that opportunity to utilize family caregivers and have those guardians get paid. And one of the things that we've heard both through that stakeholder meeting and also in our interactions with our members, that is really a key flexibility that they hope will remain. And so when you talk about policy differences, that is definitely an area that we are wondering if that will occur. Shared living. So Sunflower has been supporting a work group to propose strategies for broader utilization of shared living. Currently, shared living has been under a licensing moratorium that only those providers that have previously been approved can continue providing it. So wanting to work with KDADS to see if we can provide some support and information that can open that back up to high quality member choice in regards to shared living. Self-direction, we did see an increase in the percentage of members who self-direct their care during COVID. And, you know, one of the things that we try to do in all of our ongoing care management is really identify with members, what do they need to better utilize that self-direction. Self-direction is always a choice. It is always presented that way in care when our program specialists meet with the members, but you know, ensuring that they have those tools and strategies. So that kind of goes to the next bullet, which is visions and person-centered thinking. All of our care coordinators go through courses in person-centered thinking, as well as visions for an integrated life. So, and that really gives them the tools that they can utilize to have those conversations with individuals to say, what are your paid supports? What are your unpaid supports? What does your community life look like? Are there ways that we can help you increase that social interaction? And how can we get that support to you? And then the last thing, which was already there, but was about Connect Care. So Connect Care jobs and that. So that's all I have.
Thank you, Nan. So questions for our three representatives. Go ahead, Kelly.
Hi, Nan. Kelly Summers, Kansas State Nurses Association. I appreciate that you are actually bringing up that technology portion, because across the board in healthcare right now, it doesn't matter where any staff works right now. We have seen that has caused a decreased amount of time in providing care when we're looking at maybe charting or taking notes or something like that. And I'm talking all care, even outside of the home right now, and have looked at multiple studies regarding that piece. And so I'm glad that you brought it up, because it really does need to have additional conversation with, I would say, with even the stakeholders here on this meeting right now too. So thank you for bringing that up. And, you know, KSNA has collaborated with a lot of associations regarding that piece, but it's a lot of work. So thank you for bringing that up. I'm always happy to speak with you on that too, and share some of the data that we have related to Kansas. So again, thanks, Nan.
Any other questions?
I appreciate that. So Kelly, I just want to share, I'd already written down your name as an outreach earlier when you were sharing your one sentence. So
oh, you're so sweet.
We'll definitely.
Thank you.
Go ahead, Ernie.
Yes, Ernie Ketzley, ARP Kansas, for any of the speakers. So access to technology efforts across the state, are there areas of the state where broadband or connectivity is not available at this point in time?
So that definitely is something that that we have identified as far as broad access to broadband. Is that the right term? So, you know, for many of our pilot projects that we've been looking at, you know, identifying who those providers are in that area, and or identifying alternatives to that, whether that be hotspots or other connectivity. So, you know, it does continue to be a barrier, especially when you're looking at rural Kansas.
Hey, it's Melody from United. And I think that's an issue in areas of the state. The member care pilot that I mentioned with the show device, that comes cellular Wi-Fi enabled, so they don't have to have internet connection. And the CareBridge tablet, I believe, is the same way. So that we're trying to work around that in those areas, but it definitely, that can be a challenge.
Thank you. Haley? Or did you no longer have a question?
She just answered my question. It was how it was utilized. So thanks.
Got it. Christina?
Thank you. One of the things that I love the idea of giving technology and ensuring that access is available. However, one of my concerns is for those individuals that are very technology illiterate. You know, I mean, my father-in-law lives with us, and he can't. He can barely use the microwave. He struggles turning on his TV. Like you know, I mean, so how are we helping those individuals that don't, you know, any kind of technology is, you know, very like incredibly intimidating to them? How is that being addressed for those individuals?
Yeah, it's Melody. I'll address that a little bit with the two pilots that we have. So the CareBridge pilot, it really, there's a red button, and all they need to be able to do is push the red button in order to connect with their person. And the tablet comes to them already set up. And then if for some reason they're not able to figure out how to turn it on or something like that, the CareBridge technical team works with them. And we really haven't had any issues with any of the members so far not being able to utilize that device. The new device, the member care pilot that we're focusing on, it's more voice activated, and we wanted to try that technology for the same reason that you're talking about, just a difficulty in maybe, you know, knowing what to push and how to work things. It's voice activated, so I'm just making sure my Alexa wasn't on. So if I said something, it didn't do something, but that they would be able to use their voice. And we're selecting members who may have some communication challenges too, because we really want to test this out, right? So we chose some members that we feel are pretty comfortable with technology and will be able to do really well with this with probably no problems. And then we chose some that we thought might have a little more difficulty, just to test this out and see if it works. The company that we're using, they assure us that they can handle all 105 counties and that they can work with you know, any type of member. So we're really going to test it out with this first 100 members and see how it goes.
Thank you. Any other questions? Go ahead, Haley.
Sorry, I apologize. Quick question for the 3 MCOs. What are you guys doing as far as dementia screenings of your people that are at home in communities? I know in my experience, I have some levels of residents that have been, you know, would be able to push a red button, some that wouldn't. I'm just wondering, especially, you know, these last couple of years through the pandemic, with not a lot of face-to-face interaction, how that screening's going, because I'm wanting to see how we meet those people that are at home that maybe don't have a lot of that contact, to see their living environment, their day-to-day, you know, self-given care, if they're self-directing. Safety seems to be such a huge component to where, you know, technology can sometimes monitor some of that, but not always. And it's normally in a circumstance where safety has been compromised or something occurs, that then it's like all of a sudden someone's like, oh, they've had dementia for a while, they've been really confused for a while, and then that almost, it's at a point of no return, so to speak, for them. And then it's like, well, then at that point, then they do need, you know, 24-hour monitoring, support, assistance. So I'm just kind of curious how you have monitored or filled that gap of needs in there, or address it before it becomes an even bigger issue.
So, I mean, you are absolutely right. It's, but, you know, with the pandemic and our reduction in face-to-face visits, our care coordinators have had to really be creative and to make sure that, again, if someone isn't utilizing supports, or that's definitely a red flag. Can we reach out? You know, what can we do? if we're having difficulty reaching a member, even during the times that we were not doing in person, we were going to see them. So, you know, talking with the member when the caregiver is present. So making sure that we are having those conversations. Have you seen some changes? What can, you know, is there something we can do to support? You're right, technology on the other, you know, someone can sometimes present very differently during a, you know, 5-minute televideo call or even a 20-minute televideo call than throughout their whole day. So it really comes back to that motivational interviewing and ensuring that we're getting extra information, either from the individual or their caregiver. These pilots are, you know, our care managers are regularly, you know, helping to identify those members that we think just need that extra touch. And, you know, we're learning through that. Are we using the right technology? Have we piloted the right strategies for that?
Hey, it's Melody. The only thing I would add to what Nan has said, and I agree with everything she said, that's part of the process is monitoring their utilization of services, you know, having information from the caregiver. Sometimes you have a parent, sometimes you have a guardian, a DPOA. So it's getting kind of information from members of the full care team and not solely just the member. But I wanted to also mention on the CareBridge pilot that is available to also the caregiver and the family. So it's not just the member that can push the red button and get assistance from the care team, but it's the caregiver. So if the caregiver, you know, a worker comes in that day and things aren't looking so hot and they've got some questions, maybe some concerns, they can push the red button and talk to a physician or a nurse as well and get some assistance.
So we have about 12 minutes left for this meeting. So terrific, robust conversation. If we could keep it quick, we have one more update to do and then talk about the next meeting. And also we'll send you a survey for the recommendations. Camille, did you have a question?
No, I just really wanted to applaud. This is Camille Russell, State Long-Term Care Ombudsman. I really just wanted to applaud the use of technology as a preventative, as a way to, we know we have a workforce shortage. So we've got to support doing those types of things first, if they can be done, but not only, it's not exclusive. To make sure that we are serving the individuals who can't use technology differently, which I'm sure they're doing. Yeah.
Thank you. Kelly?
Yeah, I was gonna just, they kind of echoed what I was going to say, is that there are, like for myself as a registered nurse, I have been trained to evaluate dementia, and where people are in the stages of dementia, obviously physicians too. So I am assuming you utilize those professions, on an ongoing basis for that also? Because I think you kind of said it. I think it was Nan that said that. Maybe it was Melody.
Is that if that's a question, I think you're asking, do we utilize nurses and physicians? And yes, we do. Also, our care coordination staff are trained to be able to recognize that, and we do have nurses, licensed clinicians, and then some non-licensed clinicians who just have a lot of experience working with this population.
I thought you did, but I just wanted to kind of confirm what it was that was in my head.
Yes.
So, thank you.
Mm-hmm.
All right. Any other questions? Terrific. Well, thank you, MCO representatives, for being here today and allowing some time for questions. So I'm going to hand it over to Linda Mowbray and Deborah Zare for a quick update on reauthorizing use of trained temporary aides. I wasn't sure which one of you was going to share the update.
We're going to tag team.
Okay.
And thank you for the opportunity. We know we need to keep this concise, and so that's what we're going to do. This isn't intended to prompt debate or anything. It's just, where are we at? What is this thing? That sort of thing. So the purpose of temporary aides is to be a stopgap worker, if you will, during the pandemic to address the severe workforce shortage in long-term care settings. It is permitted, first of all, under a federal waiver, the 1135 waiver, if you're familiar with that, that will be in effect until the end of the federal public health emergency. That's still in place. It could be discontinued, but it is ongoing at this moment. In Kansas, the use of temporary aids was first authorized by the governor in an executive order. And that was used until the state public health emergency expired, which is no longer in place. And so then early in the legislative session, the legislators came in and extended the use of temporary aids until the beginning of 2023. So that's kind of the quick history of how this has rolled out. Caveat, if the feds discontinue their public health emergency before January of 2023, then it is discontinued in our state. There is no intention on the part of any trade association to try to extend this beyond a public health emergency or that sort of thing. I think that's been a rumor that's out there floating, and I just want to address that and say that we're not intending to advocate for extension of the temporary aid. We see it as a temporary stopgap measure at this time. And Linda, you're going to go over kind of what the course is and that sort of thing.
Well, when the feds through the 1135 waiver made this possible, both American Healthcare Association and Leading Age National had developed training courses for temporary aids. The states that got on board quickly with this happen to have strong ties with American Healthcare Association. So their 8-hour course was vetted fairly early. So when we did have the opportunity in Kansas to, through the governor's order, to utilize a temporary aid course, that one was up and running, and KDADS did look at that and approve it, with the caveat that in addition to the 8 hours of training, there would be at least 2 hours in the facility that's supervised by a licensed nurse before the individual would be considered complete with their TA training. Now, the modules that are online for that TA course have been updated. They have been put some security parameters in place. You know, cheaters are going to cheat, but when we heard that individuals were going through in a rapid amount of time, that was something that AHCA took very seriously and did put guardrails up so that the 8 hours of training take 8 hours. You can't zip through it. There's a competency test, and that skills checklist is something that KDADS put into place. This is not the same skills checklist that a certified nurse aide who has, done their initial 40 hours and then goes on to complete another 50 hours of training. That's not the same checklist. And in fact, the facilities have the ability to determine what tasks an individual will do. So it's not a cookie cutter. A CNA, the certified nurse aide, has been checked off on many different tasks. The TA, perhaps they are not comfortable with helping people toilet or doing pericare or giving a shower. They're not going to get checked off on that task. That's not something that they are going to be, and I won't use the word scope of practice because we leave that for our nurses, but it's not within their realm of duties. So why did we Why did this happen? Well, for one part, there simply were not enough people working. And during the pandemic, when we had staff members that were out, we have certain federal guidelines and state guidelines for qualified staffing. So if we have a dining room full of individuals that are needing assistance, and one certified aide is down the hall passing a room tray, and another one has to take a resident to the restroom, all of a sudden the dining room has no qualified staff. All right, they may have dietary staff that are passing trays or whatnot, but all of a sudden there are no qualified staff. So the TA gives the ability for, say, the office manager, the SSD, the activity director, somebody from housekeeping, laundry, or dietary to be qualified, to be in that dining room, to call for help and get assistance if need be. So in some cases, the temporary aid was simply used more as a hospitality aid and was an additional body there to give comfort and be with the residents while the certified and licensed staff were doing nursing tasks. What we did find is that individuals that became TAs that found a passion with this and said, yeah, I want to do more. A lot of them did go through CNA classes and become certified nurse aides. I know everybody wants to know what that number is. We don't have it. KDADS doesn't have it. It's up to the individual community to, number one, keep track of their TA utilization. And then, do they keep track of who became a CNA? There's no requirement that they do. If they're going to work in that facility, yes, they would know that. But there is no comprehensive database, if you will. What we do know, and these numbers are a little old. I've reached out to HCA to find current numbers, and I'm waiting, hoping that in the next 2 minutes they'll get back with me here. That when the emergency order went in place in April of 2020, through the end of the Kansas emergency, 1,289 people took the TNA course. When it was reauthorized in 2022, during the first 2 weeks that it was reauthorized, 65 individuals completed that course. And again, I apologize, I don't have today's numbers, but my contact at AHCA hasn't gotten back with me.
Yeah. One thing I did want to mention is that temporary aides have to comply with all of the background check requirements and any other requirement for employees of long-term care facilities. That there was some thought about that. And the class covers the basics of ADL care and so forth. And I think Linda did a good job of saying that based on the needs and the skills that have been confirmed on site in an adult care home, a temporary aide may do far less than what they've been trained in their course and their supervised 2-hour practicum, or they may do all of it. It's variable based on the needs of the facility. And so there are about 24 states that permit temporary aides that we're aware of right now. The records on who's employing a temporary aide is kept by the adult care home itself in our state, because these are temporary positions, there's not a thought that it's going to be ongoing into become a permanent job classification. And temporary aides, if they want to continue to do this kind of work, have to complete the full CNA course. There was quite some discussion about, well, should the course that they've already taken be applied toward the CNA requirements, and the decision in our state was no, they have to take the entire course in order to become a CNA. So those are the basic things that we wanted to just convey to you today. Any questions?
Thank you, Deborah. I'm going to hold questions for 1 second and give 2 announcements because we're at 10:31. So I'm going to ask for some grace. If anyone needs to drop off the call for another meeting, you can. Your next meeting in April is going to be on licensing and funding. So we will make sure that we send out and have experts ready to go for that meeting as well. Between meetings, I am about to drop the Google Jamboard link into chat. You are welcome to go on that today or tomorrow to put recommendations forward. Otherwise, on Monday, we will send out a survey to you to collect recommendations around this theme of workforce alternatives since we weren't able to get to the Jamboard today. With that, those of you that can stay on, really quick questions. And so that I think this meeting does pop us off around 10:35. So I saw Kelly first and then Camille.
It's a quick question that I have not been able to get an answer from KDAD, so hopefully someone has that. We have the TNA position. We're going to have another upcoming position, and I have not been able to get an answer regarding staffing. So if I have an RN and I'm supposed to have 3 CNAs to that RN, and we're talking about staffing numbers. So is a TNA or anyone else who is not licensed or certified taking the place when we only have 2 CNAs and we still need 1 more?
Yes, that's the point of this.
Yeah, they're not temporary nurse aides, they're temporary aides. And they can perform the duties up to the full responsibilities of a nurse aide. So they may well be replacing a nurse aide that, if they're short-staffed, and that's the whole purpose of this.
Okay, so if I have 1 nurse.
However, Kelly, I will tell you this, that in our reporting, both to NHSN, our payroll-based journaling reports, and on our cost reports, the TA, the temporary aide, is reported as a trainee, just the same as a nurse aide candidate that's going through the full CNA class would be counted. So they are not counted in that respect as a full certified nurse aide.
Okay, I thought under 2477 it said temporary nurse aide. So I just want to make it clear because I have so many nurses asking me this. So if I don't have any CNAs and it's just me as an RN, that I'm going to have 3 TAs taking the place of those CNAs, correct?
It's possible, but do remember that ultimately the licensed nurse is supervising, and the registered nurse may or may not choose to delegate particular tasks to the TAs.
Right.
Does the task get done later on another shift? Does the RN do the task themselves? Do they pick one TA over another who seems more able to carry out the task? The ultimate discretion is up to the nurse.
Okay, so if we're talking about meals or that kind of thing, and they can't help because, some people can aspirate or something, it would be up to the RN to help with all the meals because they don't want to delegate the task to a TNA. I just want to make it clear. I think it's kind of a touchy subject, as I think we all are want to make sure we're getting quality outcomes. So I just want to make sure that's clear when I report that. I don't want to misstate something. That's all.
Yeah, it's up to the supervising nurse on that shift to determine to what extent they are going to delegate, if you will, the tasks to a temporary aide.
Okay, so they could even bring in another nurse per se.
If there's
versus-
one in the county. Yeah.
Yeah, I know. Well, Deborah, I hear that one all the time. So thank you. I appreciate it.
All right, thank you all. And it looks like Camille had to drop off before she could ask her a question, so I will follow up with her separately. The only last announcement I want to make is the task force is thinking about meeting on May 26th. That is a Thursday before Memorial Day. Are there any conflicts from this group for that date? During that time, each of the work groups in the subgroup will report out on the recommendations developed thus far. So preliminary conversation and really any input that is necessary from the task force. That will be a good time to ask for questions before the report is finalized for the working group in June, but then for the task force in August. So if there are any conflicts to May 26th, let me know. They are still working on scheduling that meeting. All right, well, I appreciate your grace and staying on for a few more minutes. Haley, did you have anything before we log off?
I don't believe so. Did you state, do we have a whole group in-person meeting set yet? Did you state that was June, or did I misunderstand?
So May 26th is the task force meeting that I am floating the date around to see if there are any conflicts. I assume that will be in person.
Okay.
In June is when the working groups will finalize their report to the task force. The task force will meet again in August to discuss the recommendations, prioritize, and ratify the report.
Okay, thank you. Otherwise, I don't. I just thank everybody for their time.
Terrific. Thank you all for your time this morning and the extra 8 minutes. Have a wonderful day.